speaker is Charles Alvaranga, an EMT paramedic who shows us all what we are capable of. His energy and strength of character are so uplifting that he makes everyone feel ready for action. Please welcome Charles.
I want to start out with a bit of history. I believe that taking a look into the past will give us a good representation of how far emergency medicine has come today. In the early 1900s, the emergency room was just that, a room. A small section of the hospital, which on its best days was filled with minimal equipment and few staff. And the physicians that would work in this emergency room were considered lower class, but the more established departmental physicians, like dermatologists and surgeons. They were considered bottom of the barrel, physicians who needed help with their clinical practice, their physical assessment, and the patient's skills. But the emergency room has changed since then. My grandmother, who worked as an ER nurse in the mid to early 1900s, would tell me how they would sterilize needles used as catheters in between patients. How the fluid that they administered through these needles came in glass bottles. How the entire emergency room would be filled with critically ill and dying patients, and one physician to tend to them all. But then there was war. And war was one of the major factors in progressing emergency medicine. War forced pre-hospital medicine, EMS, to grow from a body transport service to a body treatment and transport service. Critically dying and injured soldiers in the field needed to be resuscitated, stabilized, and then transported to the nearest MASH tent to await further treatment. And after the war, the emergency room grew into the emergency department with more staff, more equipment, and more training. And today, emergency medicine is one of the fastest growing practices available. With radical advancements in research, technology, and care. And with large leaps and bounds, EMS, pre-hospital medicine, attempted to stay in tandem with the growth from the emergency room to the emergency department. But the emergency department changes frequently with clinical research, clinical practice, and data. I ask you to sit and think about how much your local ER has changed within the past 5 years. This year, this month. Can the same be said for the ambulance company that transports to it? Now, I'm going to put you in the boots of a medic. It's 0300 in the morning, the tones drop. You're called to a local home for a code resus. Halfway to the home, they inform you that it is a 4-year-old CPR in progress. You arrive on scene. You see a family compressing a child's chest. Instinctively, you take over CPR. You attempt to manage this patient's airway with an endotracheal tube. Now, for those of you that don't know, an endotracheal tube is a plastic tube that goes in between the vocal cords into your trachea and assists with ventilation. It is considered a primary or definitive airway. But due to a constant lack of training throughout all of pre-hospital, EMS, pediatric intubation, your airway fails. And instinctively, you reach for your secondary airway device. But now, you're back in your code. Your blood pressure is increasing. Your heart rate's rising. Your vision is narrowing. Your fine motor skills are depleting. You're compressing a child's chest, and your airway has failed. So you reach for your secondary airway device, a skill that you've learned to access every time your airway fails. But come to find out that that device does not accommodate children. That device is made only for adults, and now you have no airway. Now this isn't a common song only for EMS. Research has shown the lack of effectiveness in pediatric intubation training throughout all of medicine, including established departmental physicians in the ED. But now you're running this code without an airway. And again, I mentioned research in pointing out that it shows that pre-hospital pediatric intubation has a real low effectiveness. But to run any code without an airway, regardless of their age, will significantly increase morbidity and mortality in that patient. Now I didn't run this code. But I heard it too often from my colleagues and friends. And I told myself, I didn't want to be put in those boots. I didn't want to be placed in that position, helpless, a practitioner's worst nightmare. So I decided to do something. I decided to make a change. And this idea to make a change was almost instinctual, this guttural feeling that what if that had been my brother, my sister, my daughter, or my son? What if that had been my family without that clear airway? This was the start of my endeavor. Still enrolled in the university as a brand new paramedic, I aided the help of my business management professor, Dr. Eric Kushner, in help with the business side of my project. Because I had to change the minds and ideals of an entire company. And I had no idea where to even start. And it was all thanks to that man. A man who had no background in medicine. Had never ridden on an ambulance, worked on a fire truck, pulled a shift in an ER. I never had to see a lifeless body resuscitated before him. But he did see something that I saw back then and still see today. A need for change. Change in protocol, equipment, and treatment. And Dr. Eric Kushner wanted to help. So with internal and external research, looking at our own company's pediatric intubation attempts and successes, with physician collaboration from multiple hospitals, including our state EMS director, Dr. Brian Moore of New Mexico, through protocol revision for general airway management in pediatrics and in adults, through constant revision, but most importantly, persistent pushback from my colleagues and peers, who would say things like, "You're too new, you don't know what you're talking about, and you don't have enough experience to make these decisions." And a year later, there's a pediatric rescue airway device on every ambulance in my county. And there would not be an airway that would go unprotected from adult to neonate. Now, ironically, today it is mandated that extraglottic airways be used in every pediatric resus as a primary device for pre-hospital practitioners. But this was no doing of my own. This was the doing of extremely intelligent physicians who collaborated on a common goal and decided to make a change. Now, who was I when I took on this responsibility? Who was I when I started this project? A medic, an EMT, a firefighter? I was one of you sitting in these seats today. I was a human who saw the need for change and acted. I was one of you, sitting in these seats, watching this video, listening to this through the earbuds pressed inside of your skull. I was one of you sitting here today. I was a human who saw the need for change and acted. Now, I'm going to ask you to again analyze how much medicine in general, regardless of the department that you're in, has changed within the past 10 years. An astronomical amount. How about within the past 5? How about this year? How about today? Can the same be said for pre-hospital medicine? For most of us, it's not very true. And why? Why is EMS, why is pre-hospital medicine still stuck in the past of 5 years ago? Because emergency medicine changes on a regular basis. Now, this isn't to say that all protocols are bad, but if you think that your next patient that you see will fit inside the pages of that protocol book, sitting inside your ambulance, sitting inside your bay, sitting in the front of your fire cabinet right now, you're wrong. Pre-hospital professionals deserve to practice their passion. So today, I ask you to be leaders and champions of change. Today, I ask you to go back to your ambulance companies, your pre-hospital companies, your ERs, your fire trucks, and push for research-based protocols and guidelines. Today, I ask you to push EMS and pre-hospital medicine to today's standard. Because what we do out there in the field will set the tone for that patient for the rest of their care in that hospital. What we do will affect that patient for the rest of their lives. Your patients and your family deserve practitioners who are passionate and practitioners who are able to practice their profession. So today I ask you for change. I ask you to not be afraid to challenge normality, because together we can progress EMS from CNA to nurse, dermatologist to surgeon, EMT to medical director. We can all make a change and make a difference, even if it's for one person's life. Now I'm going to leave you with 2 quotes. The first one was told to me by my mentor, who will only be named as 909. She was from Tennessee and had a little bit of a southern drawl and a Tennessee twang to her voice. But her words still ring in my ear today. She said to me again on a New Mexico morning after 12 hours of a barrage of calls, "Now, Charlie, if you treat every one of y'all's patients like your mother, your brother, your sister, or your damn alcoholic of 10, you will never go wrong." And this struck a chord with me. This gave me the basis for the quote that I say today before every 12, 36, 48 hours of calls and nonstop sleep. I give you my quote today in hopes that it will inspire you to go forth and make a change regardless of the department that you hold or the position that you're in. And if anything, to make a quote to help you treat your next patient. I leave you with this. Remember, Charlie, remember that every patient you see today is that smiling little beautiful baby boy you call your little brother. Remember this, and you will never half-ass. You will never hold back, and you will always move forward. Remember to treat every patient like family. I'll see you in the next one.